Shouldn't you say, shouldn't you present?
And Haley, I was trying to save time. Do you want to take your...
Take mine.
So can we have a show of hand of those who operate cataract surgery under retrobulbar or peribulbar? Peribulbar? Okay. Peribulbar, okay. Please.
You notice that most or all of the injuries were above the disc or the macula. Why? Because the patient is usually afraid and he looks up while you are doing the injection. So to avoid this, make the patient fix straight and use a peribulbar needle rather than a long retrobulbar needle to avoid such an injury.
Thank you so much. So Ahmed, a quick question here, and then we'll ask also the panelists. So you prefer gas or oil in these cases? And it's a good tip not to peel over the entry side, to leave the vitreous or the membranes to close it. So gas or oil, if you have the preference?
If I have the choice, gas, of course.
And Dr. Abdelaziz?
Gas, yeah, because I'm afraid if it's fresh like the case that the silicone oil is, it will go outside. Yeah.
Not many, but I think gas would be my tamponade of choice. But I have a point here. What happens if the patient has a mature cataract and you suspect a perforation? In that kind of scenario, I think it's rather important to go ahead and do the phaco, because unless you remove the cataract, you're not going to, if you're an anti-segment surgeon, you want to go ahead and do a phaco and then refer it to a VR, because that's the only way you're going to diagnose that the patient has a perforation or so.
Thank you so much. And I think avoidance is the best, so topical anesthesia and subtenons for cataract surgery might be the best. Okay, our next speaker is Dr. Carsten Meyer from Switzerland, and Dr. Carsten is speaking to us about drop nucleus. Thank you.
Well, I'd like to thank the organizers for their kind invitation, and I think drop nucleus is a very nice topic where you combine anterior posterior segment surgery. So when I get a referral with a drop nucleus, first of all, I want to know what has really happened, and we can differentiate. Was this during an acute blunt trauma? Was it spontaneous in a pseudo-exfoliation syndrome, Marfan syndrome? So then usually the entire lens is ruptured into the vitrectomy, into the vitreous. However, we also saw numerous examples about posterior capsular rupture where either the entire nucleus is dropped into the vitreous cavity or just particles during phacoemulsification. Treatment is mandatory, and there's no doubt that this belongs into a surgeon's, vitreoretinal surgeon's hand, because you can induce much more harm if you damage parts to the retina. When the entire lens is dropped into the nucleus, you have plenty of time. Probably most of us have seen a rupture of an entire lens into the vitreous cavity. I've seen recently a patient who had this lens for 10 years in the vitreous cavity. There was no elevated eye pressure, no inflammation, so this is not an emergency case. However, for example, in Marfan syndrome, where you might face serious retinal detachments as complications, you needed an experienced vitreoretinal surgeon who takes care with the lens removal. When the capsule ruptures during hydrodissection, you may find an entire nucleus on the fundus, or it can happen during phacoemulsification. Here you can subdivide it. Is it just a soft particle which you can easily aspirate, or was it a hard, larger nucleus? So here I show you a case from a colleague of mine where already here the first part ruptured into the vitreous cavity. He continued phaco, so actually the phaco tip was blocked. He tried to aspirate it, and now he loses the second part. And while he was removing, you see already that the vitreous is coming out of his tunnel, so you have to go to vitrectomy. You have to clear the obscured view to the fundus, and once you have cleared it, then you go into the vitrectomy mode, and I tend to clear the capsule with my vitrectomy probe. With aspiration, you can nicely do it. I don't like this approach where he didn't, this was just a huge lens particle and it's always bouncing on his retina surface, and this can induce damage to the retina surface, and it takes a long time. So the bottom line here is when capsular ruptures, stop your phaco, start with a vitrectomy. So you need an experienced vitreoretinal surgeon, because once the phaco probe is clotted, you can't remove any more vitreous and you induce traction on the retina with tear formation. So during vitrectomy, you see if you do this a day later, then usually the lens is already swollen a little bit and it's easier to aspirate. So small particles are easy to be aspirated after a complete vitrectomy. We already discussed this. Should you remove the vitreous from the anterior segment or posterior segment? If it's just a capsular rupture by the end of phacoemulsification, you can easily aspirate the vitreous, clean the sulcus, and implant a second IOL. However, I tend as a vitreous surgeon to prefer the vitreous approach, because I see so many patients who after successful implantation of a lens complain about floaters, or you have still remnants that you didn't find in the vitreous cavity and the patient have elevated eye pressures. So I like to remove all and clean the vitreous up to the base before I go in and implant a second lens. No? So here So the VR surgeon, it's really important that you clean the vitreous, and especially we've seen this already, the vitreous base, especially when you get a referral, you don't know how much the phaco physician has induced traction on the vitreous base, and I tend to do a meticulous cleaning of the vitreous base, because very frequently you see tears which may induce at a later stage a retinal break and retinal detachment. So for a vitrectomy cutter, for the removal of small parts, you can use a high aspiration with a low cutting rate. I prefer 23 gauge vitrectome because it's easier to aspirate larger particles. The light pipe can be used for assistance. So the benefit, it's faster, you don't have to use PFC. However, you have to make sure that the vitreous has been removed and that you don't induce traction and that you don't touch with your vitrectome the retina. So another way to remove the lens once you have removed the vitreous is, previously we used just the lens, the light pipe. You can poke it into the lens and you can use a fragmentome. But I think nowadays, I think that a phaco or ultrasound doesn't belong into the vitreous cavity, and it takes a longer period to emulsify the lens. You have numerous particles in the vitreous. You have frequently to suture the sclerotomy of your fragmentome, and therefore I have stopped this approach. So I tend to, in large lens particles, I go for the safest approach. I try to either to remove it in the mid-vitreous by applying some additional PFC, which has makes it safe so that you don't induce any traction on the retina surface. And if I can, I also want to finish my phacoemulsification as I intended to do. So once you have a rupture and a luxation of the lens, a dropped nucleus, I clean the capsular bag. I inject triamcinolone to visualize the vitreous. I clean the periphery. I inject Dicaline, and either I can aspirate it with a vitreous probe, but if it's too hard, I elevate it up to the posterior anterior segment. Oops, this was too fast. And then you can basically remove the vitreous with your phaco on top of the PFC bubble. Afterwards, you aspirate the PFC, you um, um, until the end. So the take-home message is when you have a dropped nucleus, you have to have a person who takes care of it, who has a lot of experience. The greatest distance to the retina is the safest. So either remove it in the mid-vitreous by the assistance of PSC with a vitreous cutter with the use of the light pipe, or move it into the anterior chamber and remove it with your phaco tip. In really rare cases, I've done recently one, it was just a black nucleus, and even with phaco you couldn't dissect the lens, and I had to use manual expression. Thank you very much.
Dr. Karsten, perhaps you can come back and sit here and we can have questions as Dr. Thanesis set up for the next talk, which is connected. It's about subretinal drop nucleus and many problems. So maybe a good time for questions until we set up. So you advocate using PFCL, right?
Yes, I think it's really a safe approach, especially in hard nuclei and when you have a large lens. When you just have remnants, as I showed you, it's easy to aspirate them with your vitrectomy cutter. But if I really have a solid big lens particle, I try to elevate it into the anterior chamber, and then you don't also have to switch back and forward. With a new machine, it's easier to switch between the phaco mode and the vitrectomy mode. But in older machines, it can be really cumbersome. Then the nurse has to set up. So it really takes longer, and therefore I prefer to do the vitrectomy. And if I cannot remove it completely, then I remove the rest by anterior segment phaco. And I don't have to suture the sclerotomy from the fragmentome or something else.
Yes, one last.
Can
just
we
a
have the
comment.
presentation ready for Dr. Thanesis?
Okay.
Do you have your presentation there? Or
Yes, I think I do.
Okay, so shall we have, if you want to get it ready, Dr. Thanesis, maybe from the panelists here, do you use PFCL?
Yes, I use BFCL, but I use the fragmentome. I didn't take the nucleus to the anterior chamber. So DORC, they has advantage that you can go through the same 23 gauge and remove the trocar and do this one. I do prefer this one. And also I use the twin light. I use a bimanual, and it looked to me more easier than using the light wipe. Yeah.
Yeah, just
In very hard cataracts, I think PFCL is a good option. Sometimes I find when you're injecting PFCL, the lens gets pushed against the retina, and the PFCL bubble sometimes rides over it. So do you have any tips and tricks to make sure